And I'm happy to discuss the respiratory drive here, monitoring and managing. So these are my disclosures, nothing really related to this talk, I think. And just let's start out with a patient we probably all recognize in our ICU. So right here, this is a man who was awake and cooperative, really. He was reading a magazine while intubated, pH of 742, PCO2 low, 41, 5.4, PF ratio 140. He was on 5 of pressure support, as you can see here. And right here, pressure, flow, and volume. I'm going to start the video. You'll see that he's generating pretty large tidal volume. So I think we would all agree with this low level of inspiratory support that this patient has a high respiratory drive. So what are we going to do? And why does this patient have a high respiratory drive? I think that it's important questions I'd like to address in this topic. So first, a little bit about the physiology of respiratory drive. How do we quantify drive in our patients? What's the clinical relevance of this? And how can we modulate the drive? So first, what is respiratory drive? Well, respiratory drive is the neural output of the respiratory centers. And the respiratory centers, as you probably know, are located in the brainstem just below the pons in the medulla. And just a little bit of basic physiology, which is, I think, really exciting. So right here, you see a magnification of the brainstem, and there's at least 2 important areas. So this one is the pre-Butzinger complex, an area of interneurons that have a function as an oscillator or as a pacemaker for the inspiratory muscles only. Because there is a second set of interneurons that act as a pacemaker located in this region, the lateral parafacial nucleus, or previously known as the RTN. And this contains oscillators or pacemaker cells for the expiratory muscles. And there's much more complex physiology here for which I do not have the time to go into, but is really exciting. So right here, the 2 different oscillators. The pre-Butzinger complex, again for the inspiratory activity, and the RTN for expiration. And there is input from the body into these oscillators. So, for example, lung inflation right here. Lung inflation inhibits these inspiratory centers and activates expiratory centers. Opiates, morphine, etc., has an inhibitory effect on the pre-Butzinger, on the rate of firing, not on the magnitude. I'll come back to that later. I think this is a fantastic area, and if you're really interested, I can recommend you to read this review in Nature Reviews entitled Breathing Matters. Really exciting. The respiratory centers do get a lot of input from the body. I mean, as I already told you, from the lung, stretch receptors, irritant receptors, of course, all kind of receptors for sensing CO2, H+, oxygen, sensors from the muscles, and also from the brain, cognitive centers. I mean, for voluntary breathing, for changes in breathing pattern when we're emotional, when we're speaking, and so on. And the output of the respiratory centers, obviously, is mostly to the respiratory muscles, for the pre-Butzinger to the diaphragm, intercostals, and for the RTN to the expiratory muscles. So how do we quantify the respiratory drive? Well, obviously, the best thing would be to have a needle in your respiratory centers, but that's not very feasible today for our ICU patients. So I think a kind of second best is electrical activity of the respiratory muscles of the diaphragm, and that is more or less feasible today with this dedicated nasogastric tube with EMG electrodes that is used to drive the ventilator in a NAVA mode. The EMG signal is rather complex, but the system uses software to filter this in a couple of steps, and it gives you, as you can see here, a rather smooth signal that can help you to quantify drive, as I can show you here. So this is a patient in pressure support, so it doesn't have to do anything with NAVA. This is a patient in pressure support right here, and you'll see airway pressure, flow, and the electrical activity of the diaphragm. And if I start the video, you see that the amplitude is around 15 microvolts. Now in this same patient, I'll increase support a little bit, say from 0 to 6, and you'll see that the amplitude of the EDI signal decreases because the respiratory drive decreases. So I think this is a nice way of quantifying respiratory drive. And of course, if you don't have this ventilator, you can't use it. So there is some data that you can use surface EMG, but I think that's only for research purpose today. But very interesting is the P.1, which is defined as the decrease in airway pressure during the first 100 milliseconds of an occluded breath. And it was already described in 1975 by the group of Joseph Milik-Emely. And what you'll see here is 8 healthy subjects where unexpectedly the inspiration was occluded. And at first sight, you would say, well, these curves go all the way, right? I mean, it doesn't tell you a lot. But if you focus on only the first 100 milliseconds, you see that this is actually a very linear response. It's very reproducible, and it is very well correlated with respiratory drive. When these subjects were subjected to inhalation of CO2, there was a change in the steepness of this curve. So it is a very nice way to describe your respiratory drive. And today, almost all modern ventilators will give you the P.1 usually breath by breath, not, as shown here, during inclusion, but just measuring the change in pressure at the beginning of inspiration. And different ventilators might use slightly different techniques, but this is more or less the principle. So on your ventilator, basically breath by breath, you have an estimation of the respiratory drive. And to give you a little bit of an idea, if the patient has a P.1, less than 1.5 centimeters of water, this patient has probably a low drive. While if the P.1 is higher than 3.5, drive is probably high. So I think this is at least a very good screening method. So quantification of respiratory drive, I think EMG would be more or less the preferred technique. P.1 is a good alternative, and there might be other things. I mean, we started out with this patient with a high tidal volume, but it should be realized that tidal volume, work of breathing, not only depend on drive, but very much on muscle function as well. I mean, a patient can have a high drive, but if your muscles are very weak, the work of breathing or tidal volume will be low. So you have to be a little bit careful with that. So why would we worry about respiratory drive in the first place? Well, there are clinical consequences, and to very briefly touch upon this, first on the lung. So this is a patient with ARDS, so there's capillary leak, of course lung edema, impaired gas exchange, impaired mechanics, so probably irritation of irritant receptors, stretch receptors in the lung that increase the respiratory drive, resulting, as Laurent showed you, high changes in esophageal pressure. So increased pressure swings, which may result in additional lung injury, which has been termed by Laurent and colleagues in patient self-inflicted lung injury. So this is a way how a high respiratory drive may be damaging for our patients. But the other thing is, a high drive might be damaging to the muscle. I mean, this is just normal muscle physiology, right? If you're not using the muscle, in a short period of time, atrophy will develop. Not very surprising, right? But on the other hand, if there's a high load imposed on the muscle for a long time, this may result in injury as well. And I think there's more and more data out in the literature now that high loading occurs in our patients, in the diaphragm of ventilated patients. So if a high drive is damaging, how can we modulate respiratory drive? Let's go back to my first patient again. So, as you remember, awake and cooperative, high pH, low CO2, and This time here, he has had a pressure support of 12 centimeters of water. I guess, again, what most of you would do is reduce the level of pressure support, right? High levels of pressure support, high tidal volumes. So the first thing we'll all do, reduce inspiratory support. And that's exactly what we did in this study published in the Blue Journal last year. So these were patients recovering from ARDS on pressure support of 12, as you can see right here, but generating high tidal volumes. So as most of us would do, as we did in this study, is reduce the level of pressure support from 12 to 6. And this indeed reduces the tidal volume a little bit, from say 10 to 8.5 ml per kilogram. Perhaps a little bit better, but not fantastic. But we have to realize, once you decrease the inspiratory support, this will increase the respiratory drive of the patient, as shown here nicely with the electrical activity of the diaphragm. Reducing inspiratory support, increased electrical activity, increased drive. And therefore, the transpulmonary pressures remain more or less the same. So you think reducing pressure support is good, but at least in this study we found there was not much change in the transpulmonary, in the damaging pressures applied to the lung. Also, looking at the work of breathing performed by the diaphragm, and as we're sitting here in this room, our work of breathing would be around 0.4, 0.5 joules per liter. Our patients did already, at 12 of pressure support, have a work of breathing that was higher, 0.8 joule per liter. And now reducing the level of support further increases the work of breathing. So perhaps I'm careful here, these are the patients that will get load-induced injury of the diaphragm. So just in patients with a high respiratory drive, reducing the level of inspiratory support might not always be a good idea. And if you do it, I think it's reasonable to monitor the diaphragm effort, using the esophageal balloon, for instance. So if changing support doesn't work, probably sedation, right? So this is a nice study by the group of Paulo Navalesi, published a few years ago, patients on pressure support, so level of support, flow, and electrical activity of the diaphragm, with increasing levels of sedation. And as you can see here, increasing sedation decreases the amplitude of the EDI signal, decreases the respiratory drive. So that might be a good option. But one sedative might have a different effect from the other sedative, or in this case, remifentanil. Remifentanil might be good to control your respiratory drive, but have a good look what's happening here. So again, patients on pressure support ventilation under baseline conditions and after titration with remifentanil. So look at your EDI signal. What actually happens is you slow the rate of inspiration. Remember, the opioid receptors at the pre-Butzinger complex. So it's not going to affect the amplitude of your drive. In fact, the amplitude increased, tidal volume increased, but it only inhibits it prolongs the expiratory time. So it reduces the inspiratory rate. And this is interesting because, while working on this topic, I realized that we don't understand a lot about the effects of the different sedatives in different doses on the respiratory centers. Of course, what you could do is just complete muscle paralysis, right? Complete muscle paralysis does not, in an academic way of saying, does not really affect your respiratory drive, but it affects the mechanical output of the respiratory drive. So what we thought in this study might be a good idea, and this is really just experimental, not something that you can use in your clinic today, but we just titrate in patients on pressure support a little bit of neuromuscular blockers. So we do not want to inactivate the muscle totally, but just reduce the mechanical output a little bit. So here, again, patients recovering from ARDS on 12 of pressure support, and then we titrated very carefully a little bit of a neuromuscular blocker until tidal volume was around 6 ml per kilogram, and of course, electrical activity of the diaphragm decreased. And this was maintained for 2 hours, 2 hours only. It was a proof of concept study, but it was a nice way to modulate respiratory drive. Well, not respiratory drive, the mechanical output of the respiratory drive. And the last thing you could do, of course, a very strong determinant of respiratory drive is arterial pH. Not always, as I've shown you in my case, but very often it is, and extracorporeal removement of CO2 might be an interesting option to modulate drive as well. So to finish, Mr. Chairman, I think I've shown you that the whole control of breathing is fantastic, interesting in our ICU patients, and we're just starting to understand. So it's a cliche, but much more research is needed for that. But still, I think it's good if we could monitor respiratory drive in our patients, and P.1 is a very good start for that. And modulation of respiratory drive, for now, I think it's mainly sedation. Okay, thank you very much.